I'm talking about the hope, which is the trials, the future of our uveal melanoma. Let's see if this will work today. Yeah, I'm doing that. Is it okay now? Yeah. All right. Can we turn down the slide just a little bit, please? So we understand current limitations. We say, oh, we have radiation, the patient has radiation treatment, enucleation treatment, some resections here and there, and we worry about the metastasis. I have to say this is still not working as it should. All right, go back, please, one slide. I don't know if you're doing it manually or not, but okay, so we stop there for a moment. Okay, let's talk about radiation treatment, enucleation treatment. And generally we say, these very broad guidelines, or working guidelines. We say it's for small to medium tumors. We tell the patient, oh, good, you get to keep the eye, but you lose vision. And patient says, okay, I'm able to keep my eye and I move on. So that's the limitation what we have. When it comes to a large tumor, you say, we remove the eye, but it's going to look good. Not very satisfactory, but that's what we keep emphasizing, that the good part of it, right? And then, of course, when it comes to metastasis, say we can predict it, we can check for it, and once you get it, we have some treatments, but not that effective. Okay, we know Kimmtrak is approved and other drugs are coming, but they're not making huge differences, of course, better than before, but there's so much room for improvement. So there's all the limitations that we currently have. But I want to therefore highlight that all these are being addressed, different trials, and we'll come back to that. So if you look at from a very kind of broad perspective, like what's happened to patients with uveal melanoma in the United States over the last 40 years, 30 years. This is 1973, so that's almost 50 years. And this data is coming from SEER database, which is Surveillance, Ophthalmology, and Result Program of the NCI. Imagine like a cancer census. Approximately at present, about 35% of US population is being sampled. So not all 100% of population, but 31%, 35% of different kind of populations, rural, urban, metropolitan, like that, across US. It's a Congress, it's a Congress approved funded program going on from that many years. And every year, NCI has to produce data to tell what's happening about cancer in the United States. So it's mandated. In December issue of the journal Clinical Oncology, there's a whole supplement talks about what's happened to patients with breast cancer and lung cancer and prostate cancer and colon cancer. Just like census we have every 10 years, this is every year. It's mandated by the Congress. In that data set, somewhere is also uveal melanoma. So way back in 2000, when I came across this kind of program, I reached out to them and they said, oh, we don't publish anything on uveal melanoma. It's not important because you have breast cancer, lung cancer, colon, and all the things. And the government funding and priorities are driven from this data. Just like census gets money, similarly, this SEER program. And I want to talk about that because this is the highest quality data that exists in the world. This is the gold standard of all data of national registries across the world. Countries like in Scandinavian countries and other countries, they also have national registries with the registered data, but this is the highest quality, okay? So never, I know we all are skeptical about government, but this isn't that, this is more than that, it affects everybody, So in any case, I went to them, got the data, found someone to help me with the statistics, and we found out that there was no improvement of patients with uveal melanoma for the last 50 years. And last iteration I did with Dr. Weinberger, we just published this last year. You can see the graph is horizontal. This is adjusting for even improvement in quality of life in the United States. We know from 70s to 90s and now to 2020s, the lifespan in America has improved, except COVID time, but it went down a little bit. But in general, we say our lifespan of all people, men and women, has increased. It's adjusting for all that. And yet the curve is horizontal. That means we are not really changing the outcome of patient treated in 70s or 80s, and now it's 2020. So with all those so many lectures and so many things, I had a hard time publishing this paper in 2020 for the first one in 2004. And now every 5 years, I do on my own bring up a new data set. So this is the fourth iteration of this data set. Because NCI doesn't do it, I do on my own. So this is the fourth one. And next 5 years, we'll have another data set because it doesn't change year to year, so it's not worth that much. But in any case, this is SEER database, and I'm going to use it for my next lecture too. And say, well, why has the curve not changed? So we understand why the curve, because we know the many lines of evidence to say metastasis is very early. That means by the time patient comes to someone like me, there's already microscopic metastatic disease. It's already there. We don't have techniques to prove it, to find the ctDNA or circulating tumor cells, etc. But it's there because uvea has the highest amount of blood per gram of any tissue in the body. So this tumor is in the lake of blood, it is circulating, cells are circulating, and those cells are sitting somewhere. And in some patients, those cells, either they're too aggressive, they have some mutations, or some balance with the immune system or whatnot, things we don't understand, will convert from microscopic to macroscopic. It will not happen in everybody, but the disease is already systemic disease. It's already spread. Now it's hard for even ophthalmologists to kind of put your head around it, but that's what's happening. And you say, well, if there's early metastasis, maybe there's also room for early intervention. You say, okay, now we know this is happening, or why don't we intervene at this point? And that takes you to two kind of angles. One is to find and treat small melanomas, because small melanomas we know do better, have low risk of metastasis, and try to treat the microscopic metastatic disease. And Dr. Khan talked about it yesterday on adjuvant therapy, and we'll come back to that some more. So that's adjuvant therapy. That means treat the eye and then go after this microscopic disease before it converts into detectable tumor on CAT scan or MRI or ultrasound. Those are the two ways you can approach it. And if I have to make a guess on it and say, put my money at which one will actually make a difference, I think the adjuvant therapy will make a difference. Small melanoma perhaps will save the vision, etc., but the outcome in survival would come from adjuvant therapy. So the two ways, there's no third mechanism here. So this is kind of what you learn from this graph. And you say, so is there a trial about small melanoma? Well, so there is a trial about small melanoma, which is an AURA trial, and AURA being represented by Joyce here. And I would say it's a very nice company because they're the first time they're using a novel approach to finding treatment that are not based on radiation. So if somebody has a tumor, not sure it's melanoma or not a melanoma, sometimes you say, well, we'll biopsy it, we'll sit on it, see what happens, etc., etc. Because we are afraid that if I use radiation, then you lose vision. But if I could treat you without losing vision, then the risk-benefit ratio changes. And so you're taking away all the side effects of radiation we talked about yesterday. So this is one way to treat radiation retinopathy, is to avoid it totally, just go a different route. And this is one of those. And I think this is a very novel approach. They're injecting a drug, then shining a laser, and they have finished phase 1, phase 2 studies. So phase 1, if you think about it in very broad terms, phase 1 is to study the safety of the drug. Phase 2 is to study the efficacy of the drug. And phase 3 is generally a randomized trial. You compare with the standard and say it's better than the standard. So they're done already phase 1 and phase 2 study. That means it's safe and has efficacy. Both have been done. And you can see a tumor here that has been treated. And on a graph here, this horizontal line means absence of growth. So the tumor stayed the same size after treatment, except maybe 2 patients or so, the tumor started to grow. So they're talking about 80% control rate. Okay, so that's the phase 2 data. So you can't say take this and start using in patients yet, because you have to prove it at the next level, which is a randomized trial, which is happening now across the globe. They're looking for 100 patients. They've done about, I think they found about 100 centers. Even has to do 1 or 2 cases. And it's almost coming down to $100 million study. It's costing $1 million to find one patient to treat this. Can you imagine the cost of it? That's how much it takes. But it's happening because this company has brought this novel drug, which, if it approves or works for this, will also be used for other things, maybe even liver metastasis, for example. You could laser that, or you could go to lung, and you can go to bladder and other areas. So this is just a low-hanging fruit for them. There's not enough melanoma patients to recover their money, if you think about it. But this is where they are starting. I'm glad they're starting somewhere, and we're happy to be part of it. So that's one trial coming through. So that's small melanoma. You could have maybe early intervention and don't worry about radiation toxicity. So this is, I'm going to move away from all that, but just the more details about it. So come back now to, that's for small melanomas, right? And then we focus now on adjuvant therapy. And I think that's a bigger one. And you heard about darovasertib. Okay, so this is a targeted drug. It's not a chemotherapy. It's following a certain molecular pathway and blocks that green signal that Dr. Lucy Kennedy mentioned yesterday. This is a PET scan of a patient. So the story goes back to this. There's a patient in Australia. This is coming out of Australia, where the patient has uveal melanoma, and on scanning also is found to have liver metastasis at the same time, which is kind of very unusual. And the doctor there says, oh, we have this kind of new drug. When we try it, they tried it for the liver met, and also the tumor in the eye became smaller. And I'll show you another example here. And here, for example, you can all see that the tumor has become smaller. So if you think about uveal melanoma, and you've all read a lot, I'm sure, about it, there has never been any chemotherapy for the eye. It's always radiation, resection, removal. Well, what about some chemotherapy? Well, this isn't chemotherapy, but close, targeted therapy. You can actually reduce the tumor size. And they're showing very encouraging results. They have about 50, 60 patients by now. And the tumor gets smaller, almost 30% in about 3 months or so. So you keep taking the pill, and you get checked up every month, and you can see the tumor getting smaller. The hemorrhage goes away, the detachment goes away, the tumor gets smaller. So when the tumor gets smaller, you can do a few things from that. Well, if it was a large one, then it becomes medium-sized because it becomes smaller. So you could do, instead of enucleation, you could do radiation treatment. And if you were going to do radiation treatment, the tumor becomes smaller, then you're going to get less collateral damage. Maybe you can preserve vision. And thirdly, if it's working in the eye, what tells you that it's not working against those microscopic cells that are in the liver? So very likely, it will also increase the survival. So vision is okay, saving eye is fine, but in bigger scope of things, we say, well, if you can make that difference in survival, that really will be huge. So this is a very exciting trial. So I told you a trial about small tumors. I'm telling you a trial about large tumors and medium-sized tumors. So every category of tumor will be investigated. This trial is coming. They've already finished the phase 1, phase 2 study. Anybody here from IDEA? No, she left. Moy Choi was here yesterday. They're based in San Francisco, so she took a morning flight back. So this is neoadjuvant. Neoadjuvant means before you get the treatment like plaque or radiation, you have this pill every month for 3 months or 6 months. You keep monitoring for response. If there's no further response, you give the treatment. So say you're going to have radiation, they'll calculate the numbers, keep taking the pill. So you reach 6 months, it's no longer getting smaller than last time. You get radiation treatment to that lower height. And therefore, likely you'll preserve vision. And if it was a large tumor, perhaps you can avoid enucleation. So think about it fundamentally, like it's shifting how we think about tumors. We didn't say you have large melanoma, have enucleation tomorrow or next week. No, we say, no, hold on. You have to take this and see how that goes, and we'll take it from there. So this response they're seeing in almost 80, 90% of cases. So it's not that some patient will respond. This tumor shrinkage happens in 80 to 90% of cases, and it's almost from 30 to 50% shrinkage. So a 12 millimeter tumor could become 8 millimeters or could become 6 millimeters in height. So 12 is not radiation sensitive, for example, but 6 can be easily treated with radiation. So huge difference in how we think about the disease and how it will improve. So that's the drug coming through. They don't have to go through the technical details about all of it. And the third thing, you heard a lot about tebentafusp. which of course is an important drug, first time ever. And they were talking about this bispecific, this and that. I have an easier word for it. It's an immune magnet. Okay? So wherever the cancer cell, it goes and binds there, and like a magnet brings the lymphocytes there and fights the cancer. So it's an immune magnet. Just an easy way to remember. I can't remember fancy things. Just think about immune magnet. Okay, that's what it is. So it's working. We know it's helping improve the survival. So the idea being that if it works in patients who already have metastatic disease, why not give it before they get metastatic disease? It just makes sense. And we heard yesterday two important things. One was that patients that have smaller tumors in the liver are more likely to respond. Well, if you catch that thought and take it further, well, the tumor gets smaller and smaller and smaller. Maybe it's undetectable when you treat it. Maybe it will be more effective, right? And that's the adjuvant therapy. You say, it's undetectable tumor yet. I'm going to give it to you because you are at a risk of getting it. And therefore, so that's the atomic trial. I don't know if they mentioned yesterday or not, maybe they did. It's coming out of Europe. Atomic trial. There are some centers in the US, but it's mostly financed and led by the European Consortium. It's a Oxford-based company that came out of Oxford, spin-off from Oxford. And then you heard about percutaneous hepatic perfusion, again, newly approved drug for liver metastasis, Hepzato. It's also coming. Again, this is not for preventative because this is highly invasive treatment. You have to have infusions, this, that, hospitalization, but it's a drug for patients with melanoma. So there are a lot of trials coming through. So if you come back, I'll leave all this besides. So look at these things that we're talking about. We say we have a problem with vision loss. That is an unmet need. We say we're going to avoid radiation treatment. We have an AURA trial, right? This is one big thing for uveal melanoma. And then we say, okay, well, we decided to use radiation for whatever reason. Can we prevent radiation retinopathy? And I told you about the DRCR trial, which is my trial. We talked about that. I'm a protocol chair for that. And then we talked about the other thing was enucleation. I said, can we avoid it? Yeah, you could reduce the size by using DARVO trial that's coming. And then we talk about metastasis, and we can prevent it. So all facets of uveal melanoma that had been kind of overlooked for 25 years in my business, now 30 years, is being addressed. I really think it's the most exciting time in ocular oncology, and you're going to find many smart people wanting to come into our business because of the trials. It gets more exciting, more new things are coming, and you can kind of learn more and even do better things. So we are almost reaching, I think, what we will call where is it? Next slide. I'm coming to my punchline. Nirvana, huh? Okay. We're getting there. Well, okay. At any time in life, something is you're too late for it or something, whatever. It's coming. Okay. So you just have to hang in there. And I think next 5 years, I really think so. So before I kind of quit my business, I think we'll all be into it deeply and with tremendous improvements. And this is just a starting. And I can tell you a few other things. Why no research has happened in uveal melanoma? Because it was like 2,000 patients, 3,000 patients. There's not enough money to be made. But now, if I can charge $500,000 for a drug, multiply by 2,000, suddenly there's some good numbers there. So it's money driven. It's good for us. Doesn't matter. As long as we get going, we'll get something out of it. But this is kind of the equation behind it all. And of course, new technologies, you're able to figure out new targets and AI, designing of drugs and other things are all driving it. But biggest is this calculation, which is fine. That's how the world goes. Thank you so much.